Hi, Dr.
We are
Swati.
live.
Hello, everyone.
Welcome to our webinar.
Dr. We are live.
Nice to have you here. Happy New Year to you and to Shagnul Garu.
Thank you, and Happy New Year to everyone here.
We are live, please.
Are we live?
Yes, sir, we are live.
Okay. So good evening, everyone. It is my privilege to welcome all of you to the first MOS webinar of 2025. And the webinar is on basics of ocular oncology. As we all know, it's a very crucial field. And in itself, it's a testament to the power of multidisciplinary collaboration and research and compassionate care. Now, it's important for us all to know what to look for while examining patients in order to facilitate early detection, to be able to proceed with timely treatments. And this work that we can do has a profound impact on our patients' lives, not only their vision per se, but also some saving lives many a times. And today we're here to learn more about this critical branch. Now, this program today is bringing together some of the brightest young minds that we have in our state and some leading experts to share their insights and then discuss challenges in this ever-evolving field. So I encourage each and every one of you to actively participate, ask questions, and exchange ideas so that this experience is more enriching. I also thank Dr. Namrata Adurkar for curating this fantastic program. I will be handing over the session for moderation along with Dr. Sonal Yadav. I would also like to thank our expert panel, which comprises of my senior from LVPI and now world-renowned ocular oncologist, Dr. Swati Kaliki, Dr. Rishikesh Tadwalkar, who's a teacher of teachers, my dear friends, Dr. Mangesh Dovekar, and soon to be joining Dr. Akshay Nair, who are very young and dynamic surgeons and high-volume surgeons, as well as our speakers, Dr. Sumit, Dr. Preeti, Dr. Richa, Kruti, and Dr. Swapnil. So with this brief intro, I thank you all for joining us. And now let us dive straight into the session. So with this, I hand over the mic to Dr. Shirish Thoratsa, who's our president, for his opening statements before Dr. Namrata takes over.
Okay. Thank you, Dr. Piyush, sir. First of all, let me welcome all of you. On behalf of MOS, I will want to I thank I really thank Dr. Piyush, sir, for arranging such a nice webinar. Friends, I'm sure that with the expert panelists and speakers, this is going to be a wonderful webinar. And this is much needed webinar for general ophthalmology also. Recently, we had one DCR cadre workshop under guidance of Dr. Nair at Nagpur, and it got a huge success. And let me tell you, around 90% of the participants started doing DCRs individually. So I request Dr. Piyush and Dr. Nair to carry out such activities in the whole of the Maharashtra, five all zones. So with this, I welcome you all to this wonderful webinar, and I'll hand over mic to the Piyush one.
Thank you, sir. So let's go right into it, Dr. Namrata and Dr. Sonal.
Okay, good evening, everyone. So welcome to this webinar. We'll start with introduction of our esteemed panelist here. So is my screen seen now? Yes, so the chairperson of today's session is Dr. Piyush Bansal, who is a leading vitreoretina surgeon in Pune, and he's also the chairman of Scientific Committee, Maharashtra Ophthalmological Society. I am myself Dr. Namrata Adurkar. I am a practicing oculoplasty surgeon in Pune, and I have my own center in Pune named Samyak Clinic, and I'm also consulting at Jahangir Hospital and an honorary faculty at D.Y. Patil Medical College. I would like to welcome Dr. Swati Kaliki, who is the head of Ocular Oncology Services at LV Prasad Eye Institute, Hyderabad. She's a eminent academician with more than 300 lectures and more than 275 peer-reviewed articles, and has been named as among the top 5 ophthalmologists from India with most citations in 2023. Welcome, Dr. Swati, and we are really truly honored to have you here with us today. Dr. Rishikesh Tadwalkar is a senior faculty with a busy oculoplasty practice across Mumbai and Navi Mumbai. Welcome, sir. Dr. Mangesh Dovekar heads the Department of Orbit and Oculoplasty at Sri Ganpati Nethralaya, Jalna, and also Apart from holding a busy clinic and high volume practice, he also runs a fellowship program in oculoplasty. Looking forward to your inputs, Dr. Dobekar. Dr. Akshay Nair, who is a young dynamic oculoplasty surgeon from Mumbai, will be joining us shortly. Myself and Dr. Sonal Yadav will be moderating today's session. Over to you, Sonal, so you can introduce the speakers for today.
Yes, thank you, Dr. Namrata, and thank you, Dr. Piyush, for this excellent program and very much needed program in ocular oncology. As we all went through the introduction for the expert panel, I will take everyone through the introduction for our dynamic speakers. So I'm Dr. Sonal Yadav. I'm practicing ophthalmic plastic surgeon and ocular oncologist from Pune. Next, we are going to have 5 very young dynamic speakers taking us through different oncology topics today. First, we have Dr. Swapnil Patil talking about eyelid tumors. He is currently practicing in oculoplasty and ocular oncology in Bhakti Netralaya, Malkapur. He is from district Buldana. Then we have Dr. Richa Dharapwag. She is currently associated in Government Medical College, Nagpur, handling their oculoplasty and oncology load. Then we have Dr. Akruti Desai, who is leading the oculoplasty services at Shantilal Sangvi Eye Institute, Mumbai. Dr. Preeti Urade Bhautekar, who is working as a consultant oculoplasty surgeon and assistant professor of GMC Chandrapur. And followed by Dr. Sumit Lahane, who is director of Raghunath Netralaya, Mumbai, heading their cornea as well as oculoplasty division. Now, without further ado, I think we can go ahead and start with the first presentation of today's webinar. I would request Dr. Swapnil Patil to take over the stage and start his presentation regarding the eyelid tumors. So all of the speakers have 8 minutes to share their presentations, and we'll further move on to discussion after the presentation.
Is my screen visible, ma'am?
Yes, go ahead.
I'll start. Good evening, everybody. I'll start my topic, eyelid tumors, how to recognize and treat them. So these are the lesions we see day in, day out in our OPD. First and foremost important thing is to differentiate them between malignant and benign lesions. So this first lesion, we can see it is a well circumscribed lesion, not involving any lid margin or any eyelashes. This is a benign lesion. Then the second one, this second one lesion was referred to us as a chalazion, but this was involving both the anterior and posterior eyelid margin, and definitely it was not a benign lesion. This was to be a malignant lesion. So the telltale sign here I want to tell you that the most important signs which we can suspect as a malignant lesion are there is distortion of eyelid architecture, then there are loss of eyelashes, then there is a repeated bleeding and scabbing, and destruction of the meibomian gland lining. Many times the lesion like this can be seen as a malignant lesion, but this is a very much benign lesion which is involving, that is a melanocytic benign tumor involving both upper lid and lower lid. So the most important thing, suspicious lesion is documented growth should be there, loss of eyelashes, lid margin distortion, repeated bleeding and scabbing, and not responding to the standard treatment. Eyelid lesion can be classified into benign and malignant tumors. They can be classified according to the origin as epithelial, melanocytic, adnexal tumor, vascular origin, and neural origin. Coming to the common one, that is the squamous papilloma. They are the most common lesions seen in OPD. Once you see them, you know how to diagnose them. They are well circumscribed, can be present as a cutaneous horn or a papilliform lesion. Mostly they are of cosmetic concern and can be handled with excision. Seborrheic keratosis are disease upon appearance, arises from the epidermal layer near the eyelid margin. Shave excision biopsy gives good cosmetic outcome. Now, keratoxanthoma is a borderline lesion. Here it involves the eyelid margin, anterior lamella of the eyelid margin. These are rapidly growing tumors which can progress within days, but when the blood supply gets exhausted, there is central necrosis can be seen. They are low-grade squamous cell carcinoma. They may regress spontaneously. Sometimes they require excision with clear margins with cryo. Many times they are confused with nodular ulcerative type of basal cell carcinoma. Coming to melanocytic nevus, they can be pigmented, minimally pigmented, they can be marginal or junctional, or they can involve both lower and upper lid, such as kissing nevus. Shave excision biopsy gives good cosmetic outcome in such lesion. But when the lesion are like this, which involves the central part of the eyelid, leading to mechanical ptosis and obscuration of vision, we need a good pentagon wedge excision with direct closure or with canthotomy or cantholysis. The important thing to highlight here during the pentagon wedge resection, generally the superior part of the pentagon should be always above the tarsal height, so it will give a good cosmetic outcome. If it is below the tarsal height, then we can end up in notching and a cosmetic blemish. Oculocutaneous nevus, also known as nevus of Ota, they are associated with eyelid pigmentation, episcleral and scleral pigmentation. Generally, treatment is not needed, but one should know that this type of lesions can be associated with uveal melanoma. Though the risk is less, but it is there, one should suspect for this. There is increased risk of orbital, meningeal and CNS melanomas, also increased risk of secondary glaucomas. So when you see such patients in OPD, a good dilated fundus examination should be done, and the patient should also be screened for glaucoma, secondary glaucoma. Neural tumors can be localized nodular, plexiform neurofibroma, or involving orbits. Here we are concerned with eyelid neurofibromas, which appears as a diffuse, soft, rubbery swelling. Generally, the patient come with S-shaped lid deformity and mechanical ptosis. Treatment is required in case of functional deficit. Generally, these eyelid plexiform neurofibroma generally are present since in childhood, and the lesion increases in size with the age, as documented here. The most important goal for the treatment here is not a cosmetic outcome, but a good functional outcome. Benign adnexal tumors such as syringoma, trichoepithelioma, pleomorphic adenoma can be treated with excision biopsy. Cystic lesions such as apocrine and ecrine cyst shows transillumination, and they can be treated with excision biopsy. Many times epidermoid cyst can be present, which can be small or large. Before excision of the cysts, imaging should be necessary. We should rule out any extension of an internal angular dermoid also. Vascular tumors can be hemangiomas or venolymphatic malformation. Hemangiomas can be infantile capillary hemangiomas or acquired capillary hemangioma. Acquired capillary hemangioma generally are treated for cosmetic purpose. But in infantile capillary hemangioma, one should know this graph. There are 3 stages of infantile capillary hemangioma, that is the proliferative stage, plateau stage, and involution stage. The treatment is mostly needed in the proliferative stage. There are 2 treatment options. We can go ahead with intravenous steroid or oral propranolol. Now this child was having less visual obscuration, so we went ahead with oral propranolol, and she had a good visual and functional outcome. But in such childs, when there is complete obscuration of vision and ptosis, we have to use both intralesional steroid as well as oral propranolol. This was the result. And the treatment is completed after giving glasses and amblyopia therapy. Isolated eyelid lymphangiomas are very rare. They are generally extension of the orbital lymphangioma. Percutaneous aspiration and bleomycin gives good results. Now this 70-year-old female Aji came to our OPD with complaint of right eye watering. And she gives subtle history of trauma around 4 to 5 years back, and she was correlating that lesion with the trauma only. On careful examination, here we can see that there is the complete destruction of the architecture of the lower lid with scarring and subtle ectropion. On careful examination, here we can see there are pigmented rolled out edges which are diagnostic of basal cell carcinoma. So if this pigmented roll of edges would not have been there, one would have mistaken these lesions for a post-traumatic scarring also. So we went ahead with modified Hughes construction. a complete lid coloboma was formed, and then a tarsoconjunctival graft was raised, and the posterior lamella was sutured to the posterior lamella, and cheek advancement was done, and this was the postoperative results. Now, basal cell carcinoma can be nodular, ulcerative, cystic, or
Can you summarize, Swapnil?
yes, ma'am. Ma'am, I'll just go ahead with lid cancer. This is the case of squamous cell carcinoma. The squamous cell carcinoma, it can be like this nodular also, which we went ahead with tensile semicircular flap, and this was the post-operative picture. Then it can be superior, that is a upper lid carcinoma was treated with Cutler-Weir method. Just I will just take a minute for this. Many times squamous cell carcinoma is not generally lobulated, and it cannot be a solitary lesion, but it can present like a blepharoconjunctivitis also. It can be a vegetoid spread of squamous cell carcinoma. MAP biopsy should be done, and topical matomycin C can be given, but eventually many patients need orbital accentration also. Neoadjuvant chemotherapy is needed for downstaging of disease and for making surgery less mutilating. Lymph node metastasis should always be suspected. Every case of malignancy, one should always check for preauricular, submandibular, and submental lymph nodes. Thank you, ma'am. I was out of time. Sorry for that.
No, thank you, Swapnil. That was a very good presentation with a lot of illustrations. And though, I mean, eyelid tumors is a vast topic, we can actually conduct a day or two meeting on the same. But it was a very good effort to summarize everything in a smaller amount of time. So I would say, you know, a major take home for practicing ophthalmologist would be to differentiate benign looking lesions versus the sinister possible suspected malignant lesions. So would you just like to give us some key points of how what features to look at to kind of expedite the management or go ahead with biopsy, or in which patients we would like to observe or give them some time to decide regarding the treatment?
Whenever we see whenever we see any eyelid margin lesion, almost it can be a lesion also, but once we should always look for the lid margin architecture, loss of eyelashes, whether there is a scabbing or anything, and whether the meibomian glands the lining is good or not, means its continuity is present or not. These are the 4 to 5 signs, subtle signs, but we have to look for each and every lesion. If anything suspicious lesion is there, we should generally go ahead with wide excision biopsy with clear margins. That should be the protocol. I just want to the expert panelists to ask this question also. Yes, last week I operated a case of acquired capillary hemangioma. That was my clinical diagnosis, but it was involving the eyelid also. And then I went ahead with wide excision biopsy, and it came out to a Merkel cell carcinoma. And I didn't did any cryo. And generally, I work at at taluka places and district places where frozen section generally is not available on the same day.
Right.
So I got to know the diagnosis after around 7 days, and I'm yet to counsel that patient. I will be meeting him in the next week. So
these can be some of the tricky cases.
Yes.
So we do have very much expert panel with us for discussions today. Dr. Swati, would you like to give some pearls regarding kind of differentiating the eyelid tumors and deciding on the plan of management right from the get-go?
Yeah, thanks, Sonal, first of all. And you covered well, Swapnil, tried to cover most of the lesions. So I think I'll not come to the discussion of how to differentiate benign versus malignant, but talking about the management, yes, it's important to make a diagnosis of, if not an exact diagnosis of reaching a diagnosis of, like, say it's an eccrine hydrocystoma or Merkel cell carcinoma, that may not be as important as making a diagnosis of a benign or a malignant lesion. Because all benign lesions, we can follow the same principle of treatment, and all malignant lesions, we can follow the same principle of treatment. Once we make a diagnosis of benign or malignant lesions, yes, they need to be removed wherever possible. The entire lesion with clear margins need to be removed. And I understand the practical problems that may arise when you do not have a setup with a frozen section or most micrographic surgery. In such cases, like Swapnil, as you mentioned in one of the cases that you operated recently, there is no harm in leaving the, like, you excise the lesion, leave the defect open, just like, make sure that the cornea is adequately protected and all of it. And after you get a definitive diagnosis, you can always make sure that the margins are clear in them, which you will know by histopathology. And if the margins are clear, then you can go as a second stage, you can go ahead with eyelid reconstruction. So that is absolutely acceptable, and there is nothing wrong in doing that.
Thank you very much, Dr. Swati. Can I ask Dr. Tadwalkar to kindly provide his insights regarding the treatment or management of such eyelid tumors as well?
Yeah, so I can very well understand what Dr. Swapnil was saying, because what happens is that most of the times, as everyone is aware, oncology requires multidisciplinary help and coordination. But if your setup does not have all the facilities, what's most important is to have a high index of suspicion. And if you have a lesion which looks a little suspicious, I would counsel the patient about the need for a second surgery. And as Dr. Swati said, it's absolutely fine to leave the defect and not to be in a hurry to reconstruct it, because edge clearance is most important. And if you don't have the facility for frozen section, then wait for the paraffin section reports and the edge clearance to come. If required, sometimes what I have done is to remove additional margins medially, laterally, inferiorly, or superiorly, whatever may be the case, and sent it separately. Because sometimes, even in transport, especially in your own hospital, if pathology is not there, then this orientation can get lost. And then the information that you get from the pathologist may not be crystal clear as to if you need to go for additional resection, then which side would you resect? So therefore, send some strips of tissues in addition to your wide excision and label them medial, lateral. And that way you are clear when the report comes that if all the margins are clear or not, and then go ahead with the reconstruction.
Yes, thank you, Dr. Tadwalkar. Yes, those are very, very, very important insights. So with that, I think, Dr. Namrata, we are ready for the next case.
Yes, so the next speaker
presentation.
is Dr. Richa Darab, and she'll be giving us a peek into pigmented lesions of the conjunctiva, whether to act or to wait. Over to you, Dr. Richa.
I think, can I just add one thing for Dr. Swapnil regarding Merkel cell? That
Sure,
case
please go
that he
ahead.
had. So if you ask any of your dermatology or general oncologists, anywhere else in the body, a Merkel cell is to be excised with 3 to 4 centimeters of margin. So when I had a case, I think Dr. Swati and I had discussed about it. So when I spoke to my oncologist, he said, yeah, take a wide excision 4 centimeters. And, I couldn't help but laugh because there was nothing. Then, we discussed. So 4 millimeters is good enough. The only thing to keep in mind is if you excise a mass and 4 mm and 4 mm on either side, basically you're losing half the eyelid. And very often then you end up doing a lid sharing procedure. So if you do like a Hughes or a Cutler beard, once you divide the flap, or even while the flap is still, preferably after you divide the flap, it is now being recommended to give external beam radiation to not only the upper lid, but also the lower lid. Basically, the lid that from where the flap has come in also needs to be included in the radiation field, because they are very, very aggressive and very recurrent.
Actually, I would like to ask one question to Dr. Swati. Would you say that the margin of the clear excision, would you recommend it to be different from pigmented lesions vis-a-vis a squamous cell or a sebaceous cell carcinoma?
Yeah, thanks, Namrata. I think that is another important question that leaves everyone confused based on what is published in the literature. So generally, if you see in the literature, it is recommended that for melanoma and Merkel cell carcinoma, you have wider margins rather than just 4 millimeters. But what I practice is just any malignant lesion, I just take 4 millimeters. I think it is important to get clear margin rather than going with whatever 5 mm, 6 mm. It varies from practice to practice. But I would recommend like 4 millimeters and make sure that it is clear margin on histopathology.
Okay, with that, we'll move on to Dr. Richa. Can you please share your presentation?
Yeah, I hope my presentation is visible and I'm audible.
Yes, you are. Please go ahead.
Yeah. So good evening, everybody. We'll be discussing pigmented conjunctival lesions, whether to act or to be. I have no financial disclosures. Before we delve into the main topic, I just wanted to discuss what different conjunctival pigmented lesions can be. So they can be malignant or benign. Malignant can be melanocytic in origin or non-melanocytic. And benign can be melanocytic, pigment deposition, and others. So melanocytic is a melanoma. Non-melanocytic malignant tumors can be any pigmented neoplasia, but most commonly OSSN. Benign melanocytic lesions are nevi or melanosis, which we'll be dealing with in detail. Pigment depositions can be different like epinephrine, mascara, quinoline, iron, hemosiderin, and others basically includes an appearance of a dark appearance on the bulbar surface. It's not related to conjunctival pigmentation as such. So related to thinning of the sclera, blue sclera, metabolic disorders where there's different depositions, or conjunctival diseases where there is hematomas. So with this, we come to why are we talking about acting on it. So the indications to act, other than frank malignant lesions where we obviously need to act soon and excise it, are cosmetic concerns where it is causing a cosmetic blemish, or it is a progressive lesion and where we suspect malignancy but we are not sure clinically. So with this, we come to the first case. This is a 19-year-old girl with a dark-colored lesion of 5 years duration. As we can see, it is minimally raised and pigmented and has intralesional cysts as well. And OCT through this lesion shows that it is a well-defined lesion and it is mainly seen in the subepithelial area. This is a second case of an 8-year-old girl with a lesion, again present since 5 years, but there is complaint of increase in size and color of the lesion. As you can see, it is diffusely pigmented and deeply pigmented and having flat and raised areas. And there is no cystic lesion and it is almost around 6 locus of the conjunctiva. So an OCT shows that again, it is towards the basal epithelium and the subepithelial area, and there is backshadowing due to the pigmentation. So both of these cases are conjunctival nevi. They comprise around 28% of all melanocytic lesions. They are flat or raised. They are freely mobile over the sclera and have variable pigmentation that generally darken during puberty, and almost 30% can remain amelanotic as well. The typical feature has a presence of fine clear cysts and no feeder vessels, and less than 1% progress into melanoma. They're usually unilateral and present in the interpalpebral areas, more common in fair-skinned individuals. They can be junctional, compound, or intrastromal. Compound are the most common variant, around 70 to 80%. Intrastromal are the same thing as intradermal in a skin nevus. So these are basically very deeply pigmented. So deeper the lesion, deeper the pigmentation. This is a 57-year-old lady with a slowly progressive lesion. Now this, because of the concern of the progress of the lesion and the age, we decided to go ahead with excision biopsy, and this turned out to be a compound nevus. This is another variant where it is a giant conjunctival nevus present more than 10 millimeters, diffuse and poorly circumscribed and can be multicystic. In this particular picture, there is a lesion of, there is thinning of the sclera involved as well. Now, melanoses are all clinically macular, that is flat intraepithelial melanocytic proliferations that are not nevi. So they are melanocytic in nature and flat. So they can be congenital or acquired. Congenital can involve only the eye or even dermal components, and acquired can be primary or secondary. So ocular melanocytosis or melanosis oculi is slate gray pigmentation over the sclera, and it is unilateral and diffuse, and this is related to failure of migration of the melanocytes Oculodermal melanocytosis also involves the skin, as Dr. Swapnil had beautifully shown and explained. So depending on which dermal distributions it involves, it can be called nevus of Ota or nevus of Ito. What is the significance? Again, he has already highlighted 3 to 5% of them can lead to uveal melanoma with a higher risk of multifocality and metastasis. So a yearly fundus examination in all of these cases is very important. Like in this particular lady, she turned out to have a uveal melanoma. Now, primary acquired melanosis comprise around 11% of all pigmented lesions. These are flat, pigmented, usually present closer to the fornicial conjunctiva, and they are diffuse or multifocal. They are again seen in light-skinned individuals. Histopathologically, they can be with atypia or without atypia. PAM is an older name for it. A newer terminology is CMIN, which is conjunctival melanocytic intraepithelial neoplasia, ranging just from hyperplasia to melanoma in situ. So the risk factors are related to abundant cytoplasm prominent nucleoli with 94% chances of conversion into melanoma and 25% chances of metastasis. As we can see over here, this is the area of PAM, which is closer to the basal epithelial layer. The significance is that 35% of them progress in size. 11% of PAM do convert into conjunctival melanomas within 10 years. And melanomas, 53 to 75% of them arise from pre-existing PAM. So we can see clinically over here, there's a flat lesion, and then there is a raised melanoma over here. So a close observation for all PAM is required. This is a histopathological correlation of the same. This is a pre-existing PAM close to the basal epithelial layer from which the melanoma has actually arisen. Next is complexion-associated melanosis, previously also known as racial melanosis. It is seen in sun-exposed perilimbal regions. Most important differentiating factor is that it is present more commonly in pigmented or dark-skinned individuals, and it is static or constant in nature. And it is usually bilateral. So there is no risk of melanoma in complexion-associated melanosis. Secondary acquired melanosis is related to all non-proliferative lesions in which the melanocytes produce an excessive number of melanin granules. They are bilateral with discrete pigmentation. The causes can be related to hormones, different chemicals, and seen commonly in chronic conjunctival disorders like VKC, xeroderma, trachoma, and post-irradiation. So this is one of the last cases, a 78-year-old male with a slow-growing lesion since 2 years with decreased vision since 15 days. We can see that there is a well-defined nodular lesion with a bossellated surface and definite feeder vessels that you can see and even invasion into the cornea. So this is nothing but a conjunctival melanoma. 5% of all melanomas that are present in the ocular region. As already discussed, 53 to 75% arise from pre-existing PAM and 5% arise from pre-existing nevi. They are more seen in light-skinned individuals, and 50 to 60 years is the usual age of presentation. 20% can be amelanotic. They're usually solitary, and the most common site is perilimbal or peripulpar. Feeder vessels are usually present. So the histopathology includes radial extension, pagetoid growth, mitotic activity, and lack of maturation towards the base of the tumor, and invasion through the Bowman's layer. This is the last case just for completion. So this is a 12-year-old girl with severe photophobia and pigmentation all over the body, and she comes with this lesion present since 2 years. This is a plaque-like lesion. This is nothing but a pigmented OSSN, as can be confirmed histopathologically. So we have seen that certain cases do require excision, like these large nevi, or even clinically suspected malignancies. And there are certain flat lesions where we would like to wait and watch. So this may be a secondary acquired or primary acquired melanosis or racial melanosis as well. So this is just a small chart to help you with it. So if the age of onset is, say, childhood to puberty, and it's a static lesion and it's diffuse in nature, so it is most likely a melanocytosis. If it is localized or it is progressive in nature, it is most likely a nevus. In the age group of 20 to 40, any static lesion could be a nevus, any CAM or non-melanotic causes. And in 20 to 40 years, a progressive lesion could be PAM or pigmented neoplasia. More than 40 years, a static lesion is most likely to be CAM or non-melanotic again. And progressive lesions, either flat or raised. If it's flat, if it can be PAM. If it's raised, it can be a pigmented neoplasia. So the red flag over here is progressive in nature over here. So anything that is progressing, you would want to go ahead with treatment and excise them. So PAM and pigmented neoplasias would more likely to be excised if they are progressing in nature. In case of progression of in childhood, you would want to observe if they are just progressing at a small rate. But if the patient is clinically concerned with respect to cosmesis, then we can definitely go ahead with excision even in this particular case. So I would like to conclude by saying that junctional nevi are more likely to be histologically confused with PAM. Any middle-aged individual with a pigmented lesion that on histology lacks a subepithelial component is most likely to be PAM. Melanocytosis are benign lesions but do pose a risk to development of uveal melanoma. Conjunctival melanoma most commonly arises from PAM, almost 50 to 75% of the cases. Regular follow-up is required since it is a very aggressive tumor known to recur or metastasize. And pigmented OSSN is another mimicker which is best differentiated on careful clinical examination and histopathology. Before I conclude, I would just like to acknowledge my mentor, Dr. Swati Kalki, without whom I would not have half of my ocular oncology knowledge and practice that I do today. And I would also like to acknowledge that all the pictures of clinical photographs and the histopathology are during my fellowship period at LV Prasad Eye Institute. Thank you very much for your patient listening.
Thank you, Richa. That was a very wonderful, exhaustive presentation, and you did it in a very lucid manner, very easy for anybody in the audience to understand. What I would like to know from you is how often do you follow up these patients? You rightly pointed out the things when lesions are progressive, we need to do something about it. But till how long will you wait before actually going in and biopsy?
So clinically, if we are suspecting a nevus, then a yearly follow-up is definitely sufficient. And I think even in PAM, depending on the size of the lesion, a yearly follow-up would suffice. But in case of a lesion which, like in that particular case that I showed, he developed another flat lesion after excision on another site and in the other eye as well. So in those cases, I believe we would want to see the patient earlier.
Okay. Is Dr. Mangesh here? Dr. Mangesh, can we have your comments on following up and biopsying patient pigmented lesions?
Yeah. At the outset, actually, Richa, you presented really very well. And your summary slide was very good, actually. It showed actually what are the various ages where we can commonly get all these lesions. So in our practice, actually, most of the times what we get is the benign pigmented conjunctival lesions. And most of the times the parents are concerned that there is a brownish spot seen on the conjunctiva and they want to get rid of it. And most of the times it's rather than the functional thing, it is a cosmetic blemish and they want to actually get rid of it. So whenever there is a question of the conjunctival pigmented lesions, we should be very clear, as Dr. Swati has pointed out rightly in case of the eyelid lesions, that we should be very clear about what are the lesions which points towards the benign nature, which are the lesions which points toward the malignant lesion. So to be well aware of this, we need to have some knowledge about what are the commonly presented benign lesions. The conjunctival nevus is one of the most important thing, and she has Dr. Richards pointed out rightly that all the important features. That the important thing I actually point out most of the times is the presence of the interlesional cyst, basically. How are the margins of the lesions, where is the location of the lesion, and if there is any important feature, that is the scleral fixity. And in all these lesions, then best if I suspect it towards the most of the times the benign lesion, then I ask them to have observation, and I call them actually every 6 monthly. And even if it is not possible for them to have a follow-up, there is not a magic number of 6 months or 5 months or 1 year, but I also ask them to have a self-assessment also. Nowadays they have a mobiles, so I ask them to have a good clear photograph, and even they can assess, have a self-assessment every 3 months. And if they change, if they feel that there is any change in the size of the lesion, in the color of the lesion, and if any atypical features they found, then I ask them to report to the primary physician. So whenever there is a question of the conjunctival pigmental lesions, we should be well aware of what are the common presentations. And as we see here, the conjunctival melanoma and the uveal melanoma comparatively rare in our clinical practice. So we should be very well aware of the benign lesions like the conjunctival melanoma, and we should be ruling it out. We should be reassuring the patient. At the same time, we should not be missing the palm or the oculocutaneous lesions or the oculodermal melanocytosis. So in case, we should be very well aware that we are not missing out on the important lesions which may have a potential to have a malignancy or to develop into the melanoma. Yes.
Thank you, Dr. Mangesh. Moving on to the next speaker, Dr. Akriti Desai, and she will be taking us through OSSN management, topical therapy versus surgical excision. Dr. Akriti, over to you.
Hi, everyone. We'll just cover and discuss about topical therapy versus surgical excision for ocular surface squamous neoplasia. One second. So OSSN, as we know, refers to a spectrum of malignant or pre-malignant conditions which arise from the squamous epithelium of either the cornea or the conjunctiva. So in our examination, we need to see that whether there is presence of keratin or feeder vessel, whether there is any lymph node involvement of preauricular, submandibular, or superior cervical. And the investigation of choice is anterior segment OCT. Now, when you see a lesion like this, would you think that chemotherapy would work topical for this surface tumor or not? My first impression before I joined my faculty position at LVPI Visakhapatnam, I would probably think this would need a surgical excision. But what I did was, with one injection of subconjunctival interferon, along with topical interferon for a month, there was significant regression, as you can see. And at 3 months visit, the lesion had completely disappeared. Although a close follow-up is needed, and even after resolution of the tumor, one needs to continue the topical interferon for another 3 months. So coming to the indications of topical chemotherapy for non-invasive OSSN, it can be used as a primary treatment for small to medium lesions where surgical excision might lead to significant morbidity. It can also be used as an adjuvant therapy following incomplete excision or in cases with high-risk features for recurrence, like positive margin or extensive spread. As a chemo reduction in cases of diffuse OSSN, where surgical excision is not feasible at the first go, or for recurrent lesions post-surgery. But what is vital is the patient should be willing to follow up regularly every month. The morphological types, as we know, of OSSN are papillary, nodular, placoid, gelatinous, and leukoplakic. The topical chemotherapeutic agents that have been used so far for OSSN are mitomycin C in 0.02% or 0.04, 4 times a day, in a cycle of 1 week off, on, and 3 weeks off. 5-fluorouracil in concentration of 1% with a regime of 1 week on and 3 weeks off, and interferon alpha 2B in 1 million international units per ml for a topical dose, whereas for subconjunctival injection, 5 million international units per ml What's important to note that interferon needs refrigeration, whereas 5-fluorouracil or MMC will not need refrigeration. Also, the regime of 1 week on and 3 weeks off may be more convenient for patients living in remote areas with no access to a refrigerator. The tumor regression with chemotherapeutic agents is 80 to 100%. So this paper, which we had published, with Dr. Swati Kalki when I was at LVPI, was a retrospective study of 91 patients. And what was remarkable was the patient demographics, immune status, the chronicity or the location or the morphological pattern were not predictive of the tumor response. What is notable also is that it was found that interferon alpha 2b is an effective immunotherapy for tumors less than 6 clock hours of ocular surface in about 82% of cases. And it serves as an immunoreducing agent in tumors which were more than 6 clock hours of ocular surface in 26% of the cases. This study encompassed period from 2014 March to May 2018. Complete response was defined as regression of OSSN with no trace or residual lesion on slit lamp examination and on anterior segment ASOCT. And 3 months or more after complete clinical resolution, the topical therapy was continued. And in another study of 3 immunosuppressed patients with OSSN, interferon was found to be ineffective and showed complete tumor regression with 5-FU or MMC. Now, these are pictures from the paper where less than 6 clock hours for 3 months of topical chemotherapy, the papillary variant, as you can see on your top left, resolved very well with monthly subconjunctival injection. And the lesion, which is more than 6 clock hours, it has regressed considerably with 6 months of topical and 4 months of subconjunctival interferon. Now, a challenging variant is a corneal OSSN, which looks like a gelatinous or placoid lesion. It is often, one can see fimbriae which extend beyond the gelatinous lesion. And what helps in diagnosis is the anterior segment OCT, the features of which are classical epithelial thickening, epithelial hyperreflectivity, and an abrupt transition between the normal and abnormal epithelium. So the same lesion which you saw above regressed very well with 3 months of topical interferon. Coming to the next chemotherapeutic agents is 5-fluorouracil. Its mechanism of action is by inhibiting thymidylate synthetase, thereby interfering with DNA replication. It's effective in treatment of both primary and recurrent OSSN, especially in extensive or diffuse lesions. It's used in 1% concentration, 4 times daily for a week, and a drug holiday of 3 weeks. It is available as a injection vial with 500 milligram in 10 ml, so one needs to reconstitute it. The schedule, as mentioned, was 1 week, 4 times a day, followed by 3 weeks of drug holiday. There's another paper by which compared topical 5-fluorouracil with interferon as a primary treatment modality for OSSN. And what they found that the pain, redness, and the interferon patients did have some amount of about 19% patients had pain, 13 had redness, and some blurred vision. But eyelid edema was a feature that they found was present in about 9% patients with 5-fluorouracil as against interferon. A recent paper in 2024 by Dr. Komal Bakal and Dr. Swati Kalki showed that regression was achieved in 89% eyes with just 2 cycles of 5-FU, and the remaining 12% underwent additional treatment either in the form of excisional biopsy, extended enucleation, or had to receive topical interferon for complete tumor control. This is another picture with 5-fluorouracil for corneal OSSN as well as the lower one for papillary OSSN. I'll move on to the advantages of topical chemotherapy. It's effective in for non-invasive OSSN, which reduces the need for surgical excision, particularly in lesions which are close to vital structures like limbus, because you have stem cells there. Subclinical OSSN, wherein the other areas of conjunctiva could be involved, which are distant from the main lesion. It reduces the recurrence rate as an adjuvant chemotherapy and decreases likelihood of local recurrence. And it preserves ocular integrity by minimizing any kind of surgical damage, thereby preserving the vision and ocular function. The indications of surgery would be a poor follow-up. If you're uncertain of the diagnosis, you might want to, even if it's an extensive lesion, do an incision biopsy and confirm it, or go ahead with a complete excision with margin clearance. Or in cases of poor response to chemotherapy, recurrence post-chemotherapy, and definitely deeper scleral and muscle involvement. Now, for surgical excision of a lesion, this is a nodular OSSN, for which 4 millimeter margins with a no-touch technique need to be marked from all sides of the lesion, and on the corneal side, 2 millimeters alcohol epithelial keratectomy needs to be done. One needs to also include 1 millimeter of margin and send them separately on the filter paper by marking a drawing. You get a histopathology report which mentions
fasting and postprandial blood sugar was done. Fasting was 130 mg per year, PT was 190 mg per year. HbA1c to be done, renal function has to be done, fasting epitropion to be done.
Dr. Thora, can you please mute yourself?
Optical fluorescence tomography OCT was done. FFA to be done.
Sorry.
Take a picture of the left side showing hard X-ray.
So
you can go ahead, Dr. Akriti.
Yeah, the report would mention whether there's nuclear pleomorphism, whether there are prominent nuclei, whether mitosis is seen, and also whether it involves any inflammatory infiltrate surrounding the lesions. The margins are also clearly mentioned, and this lesion was a moderately differentiated squamous cell CA. The base of the tumor was free, and all margins which were submitted were free. For the margins, what we do after excision is change of instruments and double freeze thaw and cryo. And I'll just move ahead in this slide, we have it. And use an amniotic membrane to over the sclera and the cornea, which has been de-epithelized. So that can give you a very good outcome. One can, if one suspects involvement of the base, a cryo to the base would be a good idea. This is another patient which had corneal OSSN with a feeder vessel, and 3 months post interferon did quite well. But the following 3 months did not follow the protocol and came with a recurrence at 6 months. Considering that this patient would not be regular with follow-up, we decided to go ahead with surgery. This is the intraop image of the patient wherein an EMG was used. And this is 2 weeks post-op. I followed up the patient for over a year and is doing quite well. It is important to mention wherein HIV with OSSN is a very common feature that we've seen. And here is an extensive lesion wherein interferon was given topical as well as subconjunctival. And you see there is no regression that is happening, and the lesion has consistently progressed and eventually had to undergo extended enucleation. So to conclude, topical chemotherapy offers a valuable alternative or adjunct to surgery in management of OSSN. The choice of the drug, the agent, the regime, or the duration should be tailored as per the patient's affordability and the availability of frozen section and the possible side effects. Surgery is indicated when the diagnosis is unclear, when the follow-up is expected to be poor. Seropositive, one needs to dabble whether the patient, how is the immune status, and how the follow-up is going to be, and if there is poor response to the chemotherapeutic agent. Thank you very much.
Thank you, Dr. Akriti. That was an excellent presentation, very illustrative and very good use of pre-post images as well as the imaging modalities. So I just a question. I noticed a few of your interferon treated patients, there was topical plus subconjunctival interferon given. Was it a simultaneous regimen, or was it a tandem regimen where topical followed by subconjunctival, or was it a simultaneous protocol that you used?
So what we followed is monthly injection of subconjunctival interferon, and topical was given during the course of the month. So suppose in January, if you give subconjunctival and then 5 million international units subconjunctival, Then for the rest of the month, you prepare the drops and hand over to the patient to be used at home. And at the next visit, when the patient comes in February, if required, you would give an additional subconjunctival injection.
So do you find there is a difference between this regimen and the only topical administration of interferon regimen?
For smaller lesions, I have used just topical, which and especially like those limited corneal lesion, and it has worked very well. What in my limited experience, if there's a feeder vessel, which is very prominent, then subconjunctival interferon has worked beautifully for larger lesions. But in absence of those, just topical is what. But Dr. Swati will be able to throw more light on this. You should
I
ask.
was so Dr. Swati, what is your protocol? What do you like to follow in terms of and also would second following question would be now that interferon alpha 2b is a kind of little has availability issues in India. So what has been your experience with the alternative pharmacologically made molecule? So you could just answer both the questions.
Yeah, thanks, Sonal, and thanks, Akruti, for covering the topic of OSSN, which seems easy, but it is not easy, because especially in the setup when you see many cases which are actually mismanaged. Yeah, I think the topical treatment has been both a boon and a bane, I would say. Boon to the patients, which works when it works really well, and not so good because everyone has just started giving these topical medications, and what you see in an oncology practice is that which are grossly mismanaged and where probably it could have been managed better. Coming to like when of course interferon alpha 2b, when we had published our case series a couple of years ago, that was our first line of management. And at that time, the protocol that I had used was for all corneal lesions, we were just giving only topical medications. When there was conjunctival involvement as well, we were combining both the injection and the topical medications. Of course, there have been practices where only injection is given and nothing is done for the rest of the month. That also works. Whether only topical would work, I think that question is very difficult to answer, because you may not have the exact comparable patient where you'd use two different protocols and say which is better. But I think you can still just give injection and see how it works. It might possibly work even without topical medication as well. Coming to the availability, yes, even in India, like we had been hearing for the past 2 years, whenever you meet a colleague from the US or other places, they used to complain, oh, you're so lucky that you're still getting interferon, we are not getting. But I think we are in the situation where interferon it's gradually going out of the market, and many big companies have stopped producing it, and there are still some companies which still have it in different dosages, of course, and we are using it. But with time and with increasing evidence, we have seen that 5FU works equally well. Though, yes, compared to interferon, the side effects may be slightly more, and I wouldn't take the liberty of giving topical 5FU for 3 additional months after complete regression, which I used to do for interferon, because I know that interferon is safe. But with 5FU, I just give 1 additional month as consolidation treatment. So that probably has changed, and even we have done the comparative analysis of, because we have these 2 different eras where we were using only interferon and then we shifted to 5FU, and we mostly use 5FU now. So we have done our comparative analysis, and we have seen that the response rate is equal in both the groups, and the recurrence rate is equal. Side effects are minimal. So I think both work well. When we reach a stage where interferon is not available at all, I think 5FU still serves the purpose.
Thank you very much. Those were very insightful comments. Next, I would like to ask Dr. Akshay. So the very important indication for, or the prerequisite to start topical or subconjunctival chemotherapy is to make sure the patient has a non-invasive squamous cell carcinoma. So, Dr. Akshay, would you like to kind of elaborate that for our practicing ophthalmologist, how to make sure the diagnostic tools that we can use to make sure the patient has a non-invasive carcinoma before starting the patient on topical or subconjunctival chemotherapy.
I think that's an extension of the lament that Swati had, that it's reached a point that you see OSSN, you prescribe interferon. And the point is that if it is invasive, and when we say it is invasive is something, while you can, you have tools, diagnostic tools like ASOC to help guide you. At the end of the day, if it is going beyond the basement membrane, invading below into the episcleral space, your interferon is really not going to help. Which again brings a point of, and I wanted to make this point even in the previous talk when they were speaking about the spectrum of pigmented tumors. While we talk about PAM with atypia and margins being clear, that just underscores the need to have a knowledgeable pathologist, because our entire line of treatment, whether it's you've resected an OSSN, the margins, the base, whether we're talking about a pigmented conjunctival tumor, whether it has PAM or not, whether it's PAM with atypia or not, because PAM without atypia, like Richa said, has 0% of progression to melanoma, but PAM with atypia completely changes the scenario. So I think while interferon is not the one-stop solution, and in a way it's a blessing in disguise that now the availability is reduced. We do have pegylated interferon, which there are a couple of reports that have come out, is equally effective, but the cost, of course, is higher. It's almost 6,500 rupees per vial. But at the end of the day, it just underscores how multidisciplinary our specialty is, and involving a good, reliable pathologist who knows what they're reporting is important.
I also had one question, thanks Akshay, to Dr. Swati regarding use of interferon in OSSN in patients with xeroderma pigmentosa, interferon or 5-FU, chemotherapeutic agents. How well does it work, or does it not for patients with XP, children?
Yeah, thanks, Akruti. I think with XP, it's not because the patient has XP that it will or will not work. I think it's mainly because the lesions in a patient with XP are much more aggressive and they have more chances of having an invasive tumor. That's why probably it may not work. But there have been reports that interferon may not work very well in patients who have HIV. Because your entire the interferon, it depends upon the immune response as well. But of course, we do have patients where in HIV patients we have used, and some of them have done very well. So I think it's a multifactorial thing. Probably there is a lot to do with their CD4 counts and how well is their immune status at that point. So it's a multitude of things which actually influence. So XP, I frankly believe it's nothing to do with the systemic status. It's just what is the status of the tumor in that particular patient.
Okay, got it. Thank you so much.
Thank you, Dr. Akruti, and thank you, our experts. So I think with that, we can move on to the next presentation. Dr. Preeti would be talking about the stepwise approach to orbital tumors.
So Sonal, by the time Preeti prepares herself, actually I want to make a comment.
Oh, please go ahead.
Yeah. As far as the Dr. Swati has mentioned that she might be getting many of the mismanaged OSSN, because whenever the ophthalmologist looks at the limbal lesion, then I don't know, many of the cases even we get here is just the simple excision biopsy is done, and there is nothing done about the whether they have got the age clearance or not, whether the patient, how were the clinical features of the lesion. And these are the very important things, that whenever we operate any such lesion, any limbal lesion, it's very important that whether it is a benign lesion or it's really in the form of OSSN. So it's a very simple test actually. Whenever you are actually in a confusion whether to start only a topical chemotherapy for this, whether you want to go ahead with the surgery. The scleral fixity is a very important feature. You should not actually neglect it, or you should not forget to perform. Whenever the patient is presenting with a limbal lesion, and if you are suspecting that it could be OSSN or it could be a invasive or non-invasive OSSN, the scleral fixity is a very important feature. Any ophthalmology should not forget. And doesn't matter whether it's a small lesion or whether it's a large lesion. And when you plan to have excision biopsy, then it should be in the terms of the malignant lesion only. Okay, so you should have a proper excision biopsy with at least 3 millimeter clear margins. Then you should have a separate margins, 1 millimeter margins also. Then you should have a cryotherapy, base control, and the limbal cryotherapy as well. And then comes the role of the pathologist, as Dr. Akshay has said rightly. The role of the pathologist is very important. He should be able to comment on all the margins, base, and the main mass. And then based on that, we get the histopathology report. Then there is actually a post management that's very important, whether we want to continue the topical chemotherapy. So even my point is that we should be able to look at the very common clinical features, which may actually, if you take into considerations, the further mismanagement of all these ocular conditions or the OSSN can be avoided. Yes, thank you. Please go ahead, Dr. Kriti.
I hope my voice and screen is clear.
Yeah.
Okay. So at the outset, I'd like to thank MOS team, and it's indeed a pleasure to be part of this. So I'll start my presentation. So why are orbital tumors so fascinating? They're rare but very diverse, ranging from benign to malignant. There is orbit is a really complex structure. So many critical structures present in a compact space, and many times you require imaging and multidisciplines. And definitely, early diagnosis can preserve vision as well as life. What are the basic steps? Definitely the proper, thorough history taking, onset, progression, duration, and examination. Thorough examination is required. Specifically look for inspection. Bird's eye view is important because so that we don't miss any mild proptosis. Palpation is very important. Retropulsion test, Valsalva, vision, and fundus are important. After we do history taking and examination, at least chalk down to 2 to 3 differential diagnoses before sending the patient for a imaging. Definitely histopathology is the final thing. So basically 2 types of surgical goals are there. If you want to remove the lesion totally, that can be done only on the well-defined lesions and benign lesions. And sometimes there are diffuse lesions, malignant, inflammatory, or infiltrative lesions where only debulking or incisional biopsy can be done. So my presentation is case-based. So this is a 8-month-old female. There was a swelling in the right upper lid, which was noted 3 weeks from the 3 weeks of age. And the point is, it was a soft compressible mass and no tenderness at all. And the lesion slightly increased while she was crying. So my first DD, according to the age, and examination finding was a capillary hemangioma, which was a deep-seated one. It can be a lymphangioma or a dermoid cyst, less like dermoid because it's not firm. So we did imaging, and imaging showed a high vascular tumor. So in such cases, since it was not obstructing visual axis, we will only conservatively manage. Otherwise, we give oral propranolol. And parent counseling is important since there is spontaneous regression in most of the cases by 5 to 7 years of age. Okay, this was another case in which there was a sudden onset pain in a 5-year-old kid, which was having progressive swelling since only 2 days, but he had recurrent episodes of mild swelling since past 2 years with occasional pain and redness. There was no history of trauma. We saw eyelid ecchymosis, subconjunctival hemorrhage, proptosis, retropulsion was positive. There was tenderness, but not too many signs of inflammation. Our first DT according to age was orbital lymphangioma with the acute hemorrhage. it could have been orbital cellulitis or a AV malformation. But when we did scanning, we saw diffuse mass in intra and extracorneal space, and MRI showed multiloculated cyst with fluid levels, which are indication of internal hemorrhages, which is very diagnostic of orbital lymphangioma. So in mild cases, we do only symptomatic management, analgesics and corticosteroids. But when it is severe and progressive, we give intranasal sclerosants like bleomycin, and very rarely surgical intervention can also be done. And parent counseling is important, since this is a recurrent there is a recurrent nature of lymphangioma, and many times spontaneous hemorrhages will present. So this is another case. As you can notice, gradually progressive swelling was there since a year. There was no associated pain. You can see the elongation of eyebrows and eyelids, which shows it is a long standing and most probably benign lesion. So there was a very firm mass, non-tender, non-compressible, and it was disclosing the globe down and out. So my first DD was a schwannoma. It could have been a hemangioma and a dermoid cyst, but with the scanning, there was a well-defined encapsulated mass, very well-defined. There was no infiltration, unlike a malignant lesion. So we did a complete surgical excision, since it was a very defined lesion, and it came out to be a schwannoma. And since it's a very well defined lesion, it gives a good cosmetic outcome with very low recurrence rate. This was another girl, 5-year-old, and there was a typical history of rapidly progressive mass since 3 weeks. And there was a mild pain and restriction, and somewhere else IV antibiotic course was also given. There was a severe proptosis, downward displacement of globe, and there was an abaxial proptosis. So my first differential was rhabdomyosarcoma, and it could have been orbital cellulitis, but it has not responded to the IV antibiotic, and it could have been lymphangioma. But the very short history, we should think of a rhabdomyosarcoma and do a scan really early, so that we don't miss it. And there was a diffuse mass in the extracorneal intracorneal space, and a similar picture was in MRI. So we did a small incisional biopsy, and histopathology showed a rhabdomyosarcoma, which was confirmatory. And then we referred the patient to the ocular pediatric oncologist, and chemotherapy is the first line of management. And after chemotherapy, radiotherapy is also used. Surgery is rarely required, and regular follow-up is important in such cases. So this was another 60-year-old male, in which the patient noticed a slowly progressive swelling. There was no associated pain. There was a severe proptosis with downward outward displacement of globe, and we can clearly see there is a superior medial mass which was palpable. It was a firm non-tender mass, and retropulsion test was positive. And so according to age, my first DD which came to my mind was orbital lymphoma, which is very common in this area, and orbital pseudotumor and thyroid eye disease. So when we saw the CT scan, there was a slightly diffuse mass in superior and supromedial area involving both extra and intracorneal compartment, but there was no bony destruction. I did an incisional biopsy from that supromedial area, and it came out to be B-cell lymphoma. So we look for the systemic involvement in such cases. Chemotherapy with CHOP is a first line of management in our case, and it literally melts the lymphoma. And surgery and radiotherapy can also be done. So this is another case in which there was a slowly progressive mass since 6 months, not associated with any pain. There was axial proptosis, and the retropulsion was positive, no signs of inflammation. So my first DD was hemangioma, since it was an axial proptosis, slowly progressive. It could have been schwannoma or a thyroid eye disease also, which is confirmed by blood test. But when we did a scan, we found a very well defined lesion in the MRI. What we did was we planned a complete excisional biopsy. For asymptomatic well-defined lesion, we can wait and watch. But this was a symptomatic, and patient wanted cosmetic concern, so we did an orbitotomy, and the complete mass was removed. This is another case in which there was a slowly progressive swelling since a year, and it was not associated with pain, and it was a firm swelling which was slightly displacing the globe in the middle canthal area. So my first DD was a dermoid cyst or a schwannoma, or looking at the area, it could have been lacrimal tumor. But when we did a scan, there was a typical well-defined lesion and fat fluid level, which is a very typical of dermoid cyst, was seen. So we went ahead with a complete surgical excision since it was progressing. And in such a dermoid cyst, complete excision is possible, but we should avoid any rupture of cyst, because later it can cause even later it can cause inflammations. So this is my last case. She was a 20-year-old female. There was a sudden onset painful swelling in the right eye since 2 weeks. She also had been given a course of 5 days of IV antibiotic outside. There was an abaxial proptosis, inferior dystopia, and retropulsion was positive. There were signs of inflammation, slight. There was tenderness, slight edema of the upper lid. There were congestion and chemosis, and she came to me with a corneal exposure. So my first DD was, I thought it is orbital cellulitis, or it could be a rhabdomyosarcoma or any orbital inflammatory disease. But already she had been given IV antibiotic and scanning. She did not have scanning. When we did, we found superiorly there was a superior orbit had a hypointense lesion which was displacing the globe down. So I went ahead with incisional biopsy, which out of surprise, it was came out to be orbital inflammatory pseudotumor, and pathology suggested that it is looking like a Kimura's disease. So after that, after looking into it, I suggested serum IgE levels and eosinophil levels, which were raised, which is hallmark of Kimura's disease. So what we did was a course of a steroid. We gave cetirizine and oral azathioprine. Within a month, everything got resolved. So to summarize, when to operate if there is a progressive disfiguring proptosis for cosmetic concerns, visual impairment, or any optic nerve compression if we find. If we are very uncertain of diagnosis even after imaging and we are suspecting malignancy, we should operate. And when we can delay, if it is a stable asymptomatic and a benign lesion, very high vascular tumors, inflammatory lesions, which require steroids, and a very high risk location with a potential complication can be delayed for a while. So thank you so much for your patient listening.
Thank you, Preeti. That was an exhaustive list of tumors that you covered here. Wonderful presentation. Thank you very much. I would like to ask you one question. When would you consider doing an incisional biopsy versus an excisional biopsy in patients with an orbital disease?
Yes, ma'am. The thing is that when I find a well-defined lesion, like I have shown a cavernous hemangioma, or a very well-defined lesion which can be easily excised in toto, should be removed in toto. But whenever imaging shows a very diffuse lesion, you don't see the ends, and you are suspecting with your examination and your experience, if you feel it's a malignancy, you should do a incisional biopsy, because dermoid cyst also needs to be removed completely, and even cavernous hemangioma needs to be removed completely. But when we look for like lymphoma, you don't need to remove completely. If even some kind of debulking and then a chemotherapy, it will literally melt the tumor completely, it will be gone. So it should be on your clinical examination and imaging findings. If mostly well-defined tumors are benign.
That's right. So lesions which are diffuse and difficult to excise completely because of their proximity to important structures in the orbit, we would like to go for an incisional biopsy. Whereas any lesion that is very well circumscribed and accessible to an approach by an orbital surgeon should be removed in toto. Yes. Dr. Akshay, can we have some comments from you on orbital tumors, please?
Yeah, I think it was a very comprehensive overview. One probably thing that we could add is a lacrimal gland mass that was probably missing. Lacrimal gland, and which actually brings into focus the importance of imaging, especially CT scans. If you see sort of bony erosion, rapid increase in size, and the recent onset pain in a lacrimal gland tumor, all of them would indicate aggressive erosion, infiltration, or perhaps perineural involvement. In those cases, you have to go in, if you have a clinical suspicion, you can go in and excise it completely, go ahead and do it. Otherwise, going a transseptal route for an incisional biopsy, preserving the periosteum later for an excisional biopsy is recommended. I think that's, apart from that, I think your talk was pretty exhaustive in covering vascular tumors, benign and some malignant, across pediatric and adult age groups.
Thank you so much, sir.
Dr. Swati, can I request you to throw some light on some lesions or tumors which can be identified even before touching the patient?
Yeah, thanks, Namrata, and thanks, Preeti, for sharing your experience with different cases. I think, as Akshay also pointed out and Preeti also showed in her presentation, I think the cornerstone for diagnosis is always imaging. And also, it is important to know when to do a CT scan and when to do an MRI. I personally would prefer to do a CT in cases wherever my suspicion is more towards malignancy, because I would want to know what is the status of the bone, whether there is bone erosion. But by clinical examination, you have a axial proptosis in a middle-aged individual, then you know that more likely to be a cavernous hemangioma. Then in those cases, MRI is good. Or if you're suspecting an optic nerve lesion based on your clinical diagnosis, then yes, I would prefer to do an MRI. But otherwise, I would still prefer to do a CT scan or to know the status of the bone. So I think based on the imaging, your plan of treatment obviously can be decided based on what you see on imaging.
Thank you, Dr. Swati. We'll move on to our last presentation for the evening, which is by Dr. Sumit Lahane, 10 pearls in diagnosis of intraocular tumors. Dr. Sumit?
Yes, ma'am.
Yeah.
Sure.
You can share your screen.
So very good evening, everyone, and thank you, MOS, Dr. Piyush sir, Dr. Thorat sir, and Dr. Viral sir for giving me this opportunity to be here. And thank you, Namrata ma'am, for including me. So I'll be talking about pearls in the diagnosis of intraocular tumors. I will try to be as much as practical possible. So the whole intention of the presentation is when you see this all kind of tumor, one by one you can diagnose, but altogether it becomes very difficult as this is just an atlas of all the retinal or intraocular tumors that you see. So the pearl number one, when you see this kind of a lesion, a well-defined lesion in mid-periphery or the periphery of the retina, a dark pigmented one, and all of us very well know this is nothing but a cherpy, and when we basically try and enlarge this, just a second. Yeah. So it has some depigmented lacunae, retinal vessels not seen, and this is a very much benign lesion, which is also known as CHRPE. Now, why are we discussing it here? It has three types. The very one which we just noticed is a solitary unifocal one. There is another variety as well, which is multiple. There are multiple cherpies all over the quadrants of the retina, multifocal, and they do lack halos and lacunae. They appear as animal footprints or the bear tracks. And the third one we have is a typical one where you have a fishtail oval kind of a only one or two cherpies. Now, the whole thing is the malignant potential of all this cherpy is very less. But when you see this kind of atypical cherpy, you need to refer the patient to gastroenterologist for colonoscopy because it is highly associated with the familial adenomatous polyposis. So again, coming back to these three lesions, looking at these three lesions, the first is benign, second is just a barefoot And the third one is villainish, which you need to be careful about. Moving on to the pearl number 2. Again, a similar pigmented lesion, less pigmented compared to Cherpi, but you can see the borders. There are multiple white, small, tiny dots. And you see another lesion, again, almost the same color, juxtapapillary, but a little different than first. So let's compare head to head both of them. So the first one has yellowish orange pigment, which are nothing but lipofuscin. Second one is whitish pigment, which is nothing but a drusen. First one also shows subretinal fluid, some reduction in the vision. And if I say the first one we are talking about is a choroidal melanoma, and the second one we are talking about is choroidal nevus. Now, when you have this kind of a clear picture, it becomes very easy to differentiate, especially when they are again next to each other. But when you have a very simple single lesion or the smaller one, it becomes difficult. So for that, we have this very famous mnemonic. And I think all of us need to remember this irrespective of our specialty. The very first is we need to see the thickness of the lesion that we are seeing, more than 2 millimeters to be suspicious. Subretinal fluid with the symptomatic patient with loss of vision. Again, we need to suspicious about choroidal melanoma. Nevus generally will not lead to the loss of vision. A presence of orange pigment, not the white pigment, is again typical of what you're looking at, could be a malignant lesion. And of course, melanoma hollow that you can see on ultrasound. So just a mnemonic of 2 fine small ocular melanomas, and this was by Shields group. Moving on to the third one. So when you see this anterior segment pictures, when you are not dilating the patient, just looking at it, you know this is a dilated episcleral vessel and another pigmentation, which could be episcleral pigmentation or some extension from the intraocular mass. Now, at this point in time, you know that you need to dilate the patient and see, and you might miss or find this kind of a lesion, which is very clear, a choroidal melanoma, which we just now discussed. Now the problem comes when you have this kind of a lesion. Again, the similar features, it's a large lesion, juxtapapillary, subretinal fluid, everything. But look at the color. Color is not the way it should be. It is not a pigmented lesion. And what is it that we are looking at? This is again a melanoma, but a melanotic. Now, how can we be so sure? Other than a clinical imaging, we do have investigation also. So we do ultrasound and it shows medium to low internal reflectivity. You see a classical choroidal excavation, which is seen in choroidal melanomas, choroidal lesion, and a reflectivity which is low, of course, which can be seen on composite scan as well. Or sometimes you have a lesion like this, which is partially pigmented, less pigmented. This is nothing but by the bridge in the Brooks membrane, you have a very nice collared appearance on the B scan. So what are we looking at is choroidal melanoma. Next pearl. Again, you see this kind of a lesion, like I showed in the last slide, a little less pigmented lesion, but juxtapapillary, subretinal fluid and everything. Now, is it choroidal melanoma again? We do have our ultrasound to help. And ultrasound shows a little different picture with the hyper internal reflectivity, not too much of choroidal excavation. And what are you looking at is choroidal hemangioma, okay, which is a benign tumor compared to your choroidal melanomas. Of course, the plaque brachytherapy or the laser remains a treatment, but the differentiating point is very important because one could be life-threatening, other not. Going to the next pearl, you see again this kind of a lesion, rare to be seen, whitish yellow lesion, large one, well-defined borders. And when you image, you'll see a very classical shadow here, which is known as acoustic shadow. And a CT imaging will help you to see this kind of a calcification. So calcification intraocularly is very rare, but when you see with and correlate with this kind of a clinical image, this is nothing but a choroidal osteoma. Going to the next pearl. Now this is a white reflex, and from our first year of ophthalmology, we have been taught that white reflex is equal to retinoblastoma. But what happens when the reflex is yellow? Is it again a retinoblastoma? It could be. And when we dilate and see, you can see this kind of a lesion, both appear as a mass, a subretinal one or an exophytic plus endophytic one. Now, how do you differentiate? There are very important subtle clinical features other than imaging here. The very first is the color. You see the first one is showing yellow subretinal exudates, another is showing calcification. So what are we looking at on one side on the left? It's coats and another is retinoblastoma. Again, you see this kind of a lesion, both exudative retinal detachment and the mass is not seen only. So it is difficult to make out that which is yellow and which is white. But there is something that is still can be very well picked up clinically, and these are peripheral telangiectatic vessels. So now peripheral telangiectasia, as we know, is a very important feature of coat disease and not the retinoblastoma. Of course, there is imaging on you can on B scan you can make out total funnel RD subretinal mass, which is in the codes is yellow. And if there is a FFA available, you can see a telangiectasia very well. So now when you have a yellow reflex and you have a white reflex, UA is must, but it will help you to differentiate between coats and retinoblastoma. As you know, the treatment is entirely different. Moving on to the one more. Now you see this kind of a lesion. And again, there is some calcification, whitish mass. And as we just now discussed, white is equal to retinoblastoma. Suppose I tell you this patient is 10-year-old, then will you still call it as retinoblastoma? Of course, if the patient has taken treatment for the retinoblastoma, it could be a regress one, of course, correct. But if I tell you the patient has never taken treatment for the retinoblastoma, and we are observing year on year on year on year, it still appears the same. So what is it basically? So when you see this kind of a lesion, it could be a regressed retinoblastoma, also known as retinocytoma. It could be a spontaneously regressed one. So how do you treat? We don't treat, we basically observe. And the observation is needed because of simple reason that this still has a potential to get converted into retinoblastoma, which is again rare, but still. Point number 8, coming to my last one. So you have this kind of a lesion, again noticed on the EUA, presented with the whitish yellow reflex. There is a traction on the optic disc and there is yellowish subretinal exudate. But when you see clinically, you see these additional features of unilateral lesion, non-familial, microophthalmia, secondary cataract, and of course on B scan you can see a persistent hyaloid system. This is nothing but what are we looking at? It's PHPV. You can obviously see this extra signs like dragging of ciliary process, hyaloid artery, and in case you have a high resolution MRI imaging scene, you can obviously note a thin optic nerve stalk, which is optic nerve atrophy, and of course the PHPV in the central can be seen. So you have this kind of a dragging on the optic disc with other clinical features. We know we are looking at PHPV. So to summarize and conclude everything, keep always a high index of suspicion. EUAs are important in case of children, and complete dilated examination to diagnose intraocular tumors is very important. Ultrasound fundus image as a baseline documentation always helps, especially in the suspicious lesion. Don't miss the colors as they express the origin. Expert opinion and discussion when in doubt, as we also do with our colleagues, is very, very important. Sorry, with the paucity of time, I could not cover the metastasis and the lymphomas. Again, those are important. And I acknowledge my mentor, Dr. Santosh Unawakar, and my dear colleague Sonal Yadav for the pictures. And thank you all for the patient listening.
Thank you, Dr. Sumi. That was excellently presented pearls for diagnosis of intraocular tumors. So intraocular tumors are very interesting. Some of them, we do see array of presentations. Some of them might be incidental finding, ranging from that to acute symptoms, acute decrease in vision that is sometimes the patients do present. So Dr. Swati, from a perspective of a practicing general ophthalmologist, what would you like to add on, or what would you like to emphasize on while looking at these patients?
Yeah, thanks, Sonal. And Sumit, I think you covered a wide range of tumors in those 8 pearls that you presented, and thank you for that. Yeah, I think for any practicing comprehensive ophthalmologist, I think it's important to first, I think, do a good fundus examination, which sometimes is missing in many practices. While we say that, like, we see very few choroidal nevi or choroidal melanomas or whatever in our Indian population, I also sincerely think it's because a good fundus examination is not being done, that we do not diagnose them. And that's why we see that when the patients come to us, especially with tumors like melanoma also, they come with very large tumor because they have never been detected earlier. So I think for any comprehensive ophthalmologist or any person who's not dealing with ocular oncology, I think doing a basic fundus examination is the most fundamental thing that needs to be done. And any abnormality that they would see, be it a pigmented or a non-pigmented lesion, I think it's very, very important to send to a colleague who knows ocular oncology and who can diagnose intraocular tumors, either to diagnose what it is or at least rule out, that they're not dealing with something very serious. And yeah, I think probably this forum is out of scope for discussing about establishing a diagnosis of a particular lesion, but this is what I would say for all those who have joined this session. Please do a basic good fundus examination, and any lesion that you see, please refer to a colleague to rule out any pathology.
Thank you, Dr. Swati. Those are actually a very, very good points. And just to add, I would also like to emphasize on the importance of ultrasound when you have media invisibility, maybe because of corneal opacity or a total cataract, just so that some of the patients might not should not get missed if they do in fact have an intraocular tumor. Dr. Akshay, would you like to add in some more pearls to Sumit's necklace of intraocular tumors?
No, I think he covered it exhaustively. I think the only thing that an adjunct which he did mention is whenever you see a fundus post retinal tumor not in an adult, OCT adds a lot of information. It gives you the location, whether it's subretinal, choroidal, the appearance of the choroid, whether the photoreceptor layer is intact or not. SRF, which is again a very good indicator of activity of the tumor, like in hemangiomas and things like that. So I think just to add to that, that's the only thing I wanted to add. I wanted Namrata to ask, but I'll ask Swati. Swati, if you want to expand on our mnemonic that we were discussing. Sumit mentioned that, but the shields have then gone ahead and made it longer to differentiate between nevi and melanoma.
Yeah. So Sumit did mention about the TFSOM. Of course, there are other the mnemonics that have expanded beyond that. Like it is to find small ocular melanoma using helpful hints daily. That means there is an addition of UHHD. So UH standing for ultrasound hollow, H stands for halo being absent, and D stands for drusen absent. Then of course there is another mnemonic that has been given by the Shields group itself based on the different imaging techniques, where they called it as UFSOM TFSOM DIM. That is to find small ocular melanoma using imaging, where it is the T, that is the thickness, where you you note the thickness of the tumor using ultrasound. F standing for fluid, you detect that by using OCT. S standing for symptoms, that is if there is any vision loss, that is by visual recording. Then O, that stands for orange pigment, it is that you see for it on autofluorescence. Then M, which stands for the melanoma hollow, which you detect on ultrasound. And DIM, that is DIM, which stands for diameter. That means if it is more than 5 millimeters, which you detect on serial photographs. These are all which help you to diagnose melanoma. So these are different mnemonics that have been given. Of course, the basic, at least all of us at least should know the TFSOM, and it has expanded beyond that. I think one point I would just like to add for the audience who have joined here, I think any intraocular lesion that you see in a child less than 5 years of age, please consider it as retinoblastoma unless ruled out. So that is one important thing, because I don't think any ocular oncologist would mind to see as many pseudoretinoblastomas, not to miss just that one case of retinoblastoma, because it's something that if it is missed or mismanaged, then it's like we might lose a child. So yeah, just keep that in mind, that any intraocular lesion that you are seeing, any mass that you're seeing, you're not certain of, always keep retinoblastoma in your differential diagnosis, and keep it in the first differential diagnosis in a child less than 5 years of age. And always refer the patient, the child, to your nearby ocular oncologist.
So may I take a minute?
Yes.
Yeah. Just in addition to what Dr. Swati said, any intraocular mass lesion, but what we present, what we actually receive clinically, any patient less than 5 years of old, painless blind eye or painful blind eye, you consider it as a retinoblastoma unless proven otherwise. So it's onus on the ophthalmologist that it's not a retinoblastoma, because we may get many such cases which may actually progress to the orbital retinoblastoma, and the potential, actually the survival then drastically reduces. That's it.
Yeah, thanks, Mangesh. I think that's a very, very valid point. And just in continuation to that, I think if a child requires removal of the eye for any reason less than 5 years of age, unless it is clear-cut trauma, of course, it's always better to do enucleation rather than evisceration. Because you don't know, you might be missing a case of retinoplasma, and you do not want to be doing an evisceration in such a case. So, and you're not going to change anything for the child, whether if you do enucleation in place of evisceration, even if it is not a retinoblastoma pathology, because the cosmetic outcome, everything would be similar. So I think that is one more thing to keep in mind. And they can also present in other forms, like painful blind eye, as mentioned by Dr. Mangesh. Of course, they can also present with just a cellulitis-like picture, which might be just misdiagnosed as an infective pathology, but it might be that there is an underlying tumor inside the eye which is causing the cellulitis-like picture. So all these are things that should be kept in mind.
Thank you, Dr. Swati. Thank you, Dr. Mangesh and Dr. Akshay. Those are very, very important insights while dealing with some of the intraocular tumors or patients with intraocular tumor. The very, very important, I think, baseline. Again, I would just like to repeat what Dr. Swati has mentioned. A routine or a complete dilated fundus examination is a must while looking at patients of any age group whenever the patient first presents to you, or or continuing that annually. That would actually help catch many of these tumors which are asymptomatic to start with, and not wait till they get larger and create symptoms. So that might help us catch them earlier. With that, I think we are almost at the end of our session, completing all of our speakers' talks. We do have a question on one of our YouTube forum. Dr. Sonali has asked, if the conjunctival nevus, which is benign one, and if the patient wants to excise, should we take the margin of 4 millimeter? And what if the nevus is also involving limbal area around 2 cloaca? So we did have extensive discussion regarding the pigmented conjunctival lesion. So with the so I would ask Dr. Akshay, would you like to just answer the same?
Yeah, I think if it's a conjunctival nevus with which you've clinically seen has very distinct margins, you've documented over time, and you're sure, I think you can go and keep maybe 2 margins for safety and for good luck. But even if you go flush, as long as there's no corneal extension and you don't find anything unusual intraoperatively, you're good. I think nevus is something that has a high specificity on clinical diagnosis, and rarely do you go wrong. But if there's any sort of a doubt, you can always go ahead and take some wide margins. I would not go so much as to do cryotherapy, but yes, wide margins for sure, and AMG or an autograft, depending on your surgical preference.
Yes, I would also echo what Dr. Akshay has said, and I always err on a little bit more cautious side. I would still like to go maybe 3 or 4 millimeter, and specifically if you find pigment dusting around the lesion, because it might not be a very straightforward diagnosis, even with clinical findings as well as the ASOCT findings. If there is any irregular pigmentation, irregular density or pigment dusting around, I would like to take the full advantage at the same setting, because the whole point that you are going ahead with the surgical excision is to take care of the disease once and for all. So that would and followed by a good histopathological analysis of the lesion. So that should that should be able to take care of it.
Yeah, I think like Dr. Swati summarized in eyelid cases, I would follow the same even for conjunctival lesions. I would go with the 4 millimeter margin, whether it is clinically looking like a nevus or anything else, anything more vicious. I would still go ahead with a 4 millimeter margin for a pigmented conjunctival lesion.
Can I just add to the ongoing discussion on this? So I think if you ask the same question to anybody in the US or the white population, they would say that, okay, I will just treat it like a malignant lesion, even if I know that this is a benign lesion. And they have a reason to say that. That's because they have relatively higher incidence of melanoma. But if we are talking of our population, where the incidence of conjunctival melanoma is like really, really low, and if the diagnosis, the clinical and OCT diagnosis is more towards a benign lesion like a conjunctival nevus, what I practically do is I would just take 2 millimeters of margin. I'll not just go in flush with the margin, just take 2 millimeters of margin and will not do cryotherapy or anything, and I would just excise that. That's what I follow, and I think that's good enough for a population where melanoma is really rare. We might be otherwise over-treating is what I would say, because most of these lesions you will be seeing in very young children, and why would you want to sacrifice 8 millimeters of normal conjunctiva, taking 4 millimeters all around the tumor?
I had a couple of questions for the expert panel, if we have some time. Yeah.
Go ahead.
Yeah, so one was regarding PAM. Dr. Swati, what has been your personal experience with PAM, and in cases of suspicious, progression, how would you go about managing it? That was one. And secondly, the discussion that we were just having regarding excision. In your experience, have any of you seen recurrence after excision of a conjunctival nevus?
Yeah, thanks, Richa. I think very, very important question that you brought about PAM. If it is just less than 1 clock hour, the recommendation is that you can just observe it. If it is a larger PAM, more than 1 clock hour, most of the practices would suggest excisional biopsy, especially if it is a patient that you're dealing with in a white population. In our setup, if it is less than 3 clock hours, I would still just observe it. If it is more than 3 clock hours, I would prefer to excise it. And I think here one important point, probably a new learning that has come through in the recent years, is never do an incisional biopsy from PAM. Previously, we used to do that. Even I have done incisional biopsies in the past. But the new learning now with the new evidence is that if you do a biopsy in the PAM, you are going to seed that tumor elsewhere and the patient can develop tumor. So the current recommendation is that if you are going to surgically intervene in a case of PAM, it has to be excisional biopsy and not incisional biopsy. Still, there might be few exceptions to this, like if it is a very diffuse, like, say 270 degrees of the ocular surface being involved, it's practically not possible to excise the entire ocular surface. In those, maybe I would make exceptions, but otherwise, wherever you can excise, it's best to excise the lesion. I hope that answers the first part of your question. Coming to the second part, do conjunctival nevi recur? I would say yes, if you haven't excised it completely. Like when I say recur, it's just that spillover pigment can occur, and that's more common if you are just excising the lesion in flush with, like, just the exact lesion. If you're just taking out, then there might be few pigment cells that might be present, and with your surgery it can proliferate. It's not exactly the nevus cells that are growing, but it is the pigment that kind of, like, disperses, and which can appear like recurrence of the nevus. So you would see some cases that you have done excision, and the patient comes back after a year or so and saying, like, it had disappeared and now it has slightly become like, browner in that area. So yes, that can occur. It's not exactly like a recurrence of nevus, but it is the appearance of a nevus that occurs there because of the pigment that can disperse there.
Dr. Swati, a couple of reports of treatment of PAM with interferon in combination with retinoic acid. Do you have any experience with that?
Yeah, I personally really haven't used. I know there are a couple of reports even about using mitomycin C. There are a couple of reports using interferon alpha 2B, where they have, of course, you see the pictures and it's like a dramatic change in that. But I do not have personal experience on use of these. But I have done in a couple of cases, I have done cryotherapy. Like if it is PAM with melanoma and it is extensive PAM that is there, I have excised most of the PAM, whatever can be excised, and the remaining pigment, if it is too extensive, I've done cryotherapy. And yes, with cryotherapy, it does regress. But topical medication, I really do not have experience with it.
I think what we see less in pigmented tumors, we make up for in sebaceous gland carcinoma in the Indian population.
True.
Thank you everyone. So with that, we conclude today's session. I would like to ask Dr. Piyush Bansal to give his vote of thanks.
Such a lovely session, full of learning. I think it was not just basics, a lot of advanced was also probably covered. So I have Dr. Namrata Aruka to thank for this, for not just curating, but gathering such a fantastic group of not just young speakers, but such fantastic faculty. Akshay, thank you. Thank you, Swati Garu. Really thankful for all the comments and the discussion. Mangesh sir, thank you. And we also have non-ophthalmologist Viral sir joining in, who's the secretary of MOS. So perhaps he can just say thank you to all of you all for taking the efforts. Thank you, Dr. Sonal. You moderated fantastically. So, Dr. Viral.
Dr. Piyush, you do the honors, please.
Thank you, everybody, and hope we can continue this and with the next few modules. And I'm looking forward to having Dr. Swati joining us in teaching more of oculoplasty and oncology in the future sessions. Thank you very much.
Thanks, everyone. Thanks for the invitation, and
Thank you.